Thank you, Dr. Rahman, and good morning, everybody. Actually, I'm in California right now, so it's about 7 in the evening, and we are going to be talking on a complex PCI, and we will go through some cases. When we talk of complex PCI, let's take a look at this particular case. This lady was put on
Recording
treadmill,
in progress.
and she had positive response, strong positive response, in less than a minute. So she came for an angiogram, and you can see the RCA osseum, critically diseased, and it's a dominant vessel. The left main is really a long length, so it's something like 60 meters. And beyond that, there is a disease which we'll see in some other angles. But the other issues where she's diabetic for almost 10 years and creatinine is raised. So we have to be very careful as to what we are going to do, whether we are going to do everything in one sitting or do two different settings, one for left, one for right artery. So here, to save on contrast and get good support, we have, instead of JR, which was used for diagnostic angio, we have an AL catheter. And we purposely chose a hydrophilic wire so that the wire can move in very quickly and we can save on contrast. That was one very important. Second question is why we are doing right first when there is so much disease in the left artery. It is probably to achieve some respect of stability when we are doing left. This lady had a treadmill positive inside seconds at stage 1. So obviously there was a huge amount of ischemia. Fortunately, the left ventricle was pretty normal. This is a balloon dilatation, and then we come in with a stent from the RCA osseum, and the stent was stretched with an NC balloon, and this is the final result. Obviously, we keep the few struts of the stent back in the aorta to cover the beginning of the RCA. Once we achieve this, I think we're a lot happy in the sense patient would probably be far more stable. So you can see the RCA is a very dominant vessel, and distality, there are no lesions at all. So then, having achieved a good result here, the patient was also hemodynamically more stable. So we go to the left, and here we have a long left main, and you can see the circumflex osseum is critically narrowed, close to 99% with very little flow. However, it's a good size circulation. You can see in spider view a long left main, which was quite normal. So since the creatinine was high, we decided we will choose one view which will show us most of the lesions. So this is one way in which you can limit your contrast injection. And this we chose light RAO with a steep cranial angle. And we kept working in this view all the time so that we don't have to look at the contrast injection again and again. Here we find a very, very critical narrowing of the circumflex after the origin of OM1 branch. This was probably 99% and could be possibly the reason for ongoing edema. In addition, the ramus or high diagonal is showing a critical disease with disease in the mid-segment of LA. So we said we will use this image as a frame on which we will base our strategy and go further. As we said earlier, we wanted to save on contrast. And here, that's why we used a filter XT wire, which we thought would slip in and we can limit on contrast. So filter XT wire is sent to OM1 first. You can see a micro catheter just at this point where the circumflex is going up. You withdraw the wire filter XT from the OM1 and place it into the circumflex, as you can see here. Once this was placed, we decided we would use, we intentionally chose hydrophilic wire because we wanted to limit on contrast. So there is a hypercoat going to LAD in the first picture. Then we have the another hypercoat going to OM1 branch. So all three wires are in good position. We circumflex the OM1 and the LAD. At this stage, we decided we will stent the mid-LAD lesion. So balloon to mid-LAD, stent to mid-LAD. And the stent, of course, we kept it away from any bifurcation. The stent is entirely placed beyond all the complexity of the bifurcation. And so this stent is deployed here in the mid-LAD. High pressure inflection was done. And now we are looking at the circumflex. So here you can see a balloon dilatation. The microcatheter brought in a little bit. And we generally, when we are doing, we chose a strategy where we would address both main branch as well as side branch. So this is the mini crush technique, and balloon dilatation to circumflex with a microcatheter. Wire is already there in the OM1 branch. After doing balloon dilatation, we bring in a stent which slips in quite easily. And then we thought as a strategy for mini crush, we would bring in a stent to the OM1 branch. However, we could get a stent sizably inside, but because of distal bends, this was not going any further. So we had to sort of struggle a lot. This was supported by the microcatheter. However, just could not go further. So we did repeat that, and yet it did not go. So we withdrew the stent which would have gone into the OM1 branch, and then dilated the into the circumflex stent. The back end, of course, had to be positioned very carefully, matching with the wire position. So we have one stent in the mid-LAD, which is dependent. Then the second stent is now in the circumflex after the origin of OM1 branch. And then we remove the wire and then bring in the stent to the OM1. So here the stent slips in very easily. We had to be very sure that the back end of the first stent going towards the circumflex would match the stent in the OM1 branch. OM1 branch, the back end is kept at the origin of the circumflex vessel. This stent is deployed. We always like to bring back the balloon a little bit and go high pressure. We always do that so that it makes balloons don't go easily. We've done, at least to some extent, a high pressure inflation. So this was the stent strategy, the circumflex stent starting from the origin of the OM1 branch. Then a mini crush technique with a third stent going to the OM1 branch. So this was the mini crush. We're of course withdrawing the wire because this patient was extremely unstable, and we didn't want to sort of waste time doing the kiss and high pressure inflation at this stage. So we wanted to get the flows first. That was the principle. So once we did this, we had a good stent in LAD, good stent flow in the circumflex, and good flows in the OM1 branch. We now decide to come to the first branch of, let's call it a D1, and this branch was then wired. The LED was also again wired, and so we are going for a bifurcation at this particular point. So this is the pre-dilatation NC, then a stent is brought into the diagonal branch. Another stent is brought from mid portion of the left vein to touch the stent which was already deployed, and this was a 4 millimeter stent. And so this was the final position, a mini crush again between the diagonal one with a stent going from left main to LAD. And the stent was deployed as usual. We pull the balloon back and go high on pressure so that we are trying to avoid a possible dissection at the distal end. And this is the contrast showing force flows through 4 stents which are deployed: LAD, the circumflex, the OM1, and the diagonal. I think the flows look quite good. So we are quite happy at this stage and ready to deploy the stent which is going from left main to the deployed LED stent. Must make sure that the overlap is quite correct. It was then deployed. At this stage, you can see all the stents on fluoroscopy here. We are doing a pot, and for pot, we always like to keep about 6 to 8 millimeters length in the proximal portion, so that the stent balloon can fit inside the metal, and we go very high pressure. So this was done. You can see all the 5 stents here, and this is the pot, and then we are now going to go for bifurcation. So what we have achieved is got the stents 1 in right and 5 in left, and flows are normal. So the patient was very stable. Otherwise, for every little inflation, patient used to get severe pain, cross-ST depression, and hypotension. So we now put a wire in the diagonal, do NC balloon dilatation to the deployed LED stents, and then do a kiss between diagonal and LED stent, and thus high pressure inflations were given. Once we did that, we switched the wire to the OM1 branch and did another kissing dilatation with the left main LED stent, and then making sure that there is no problem at the distality of any of these stents. We could even withdraw the wire from the OM1. This is the lesion at the bifurcation, which we did not address with kissing, because I think taking wire through this was getting very difficult, and we did not want to disrupt a nice looking in the one branch. Then we do a final pot or repot. This is the position. So you can see in the final analysis, it flows through all the 5 stents on the left side. are looking very good. And this is despite a very long left main, 60 millimeter long left main. Generally a worry for an angioplasty. So you could see here the pre-lesions in the left system. This is the way the stents are placed, and you can see nice flows in all the stents. So we kept using this angle and occasionally an RO control, mostly for distal wiring, circumflex, and distal wiring into LAD. And so this was our final results in this patient. So all stents were placed as a mini crush technique. As I mentioned to you, we wanted to save time and contrast because creatinine is high. And this is our final position. The RCA first, you can see a very big dominant circulation. So once you achieve stability with this kind of circulation getting normalized, you can play around a lot with the complexity of the left side. This is the second case I want to show you. And this patient was actually placed for surgery because he had grade 3 mitral regurg and PA pressures.
I apologize. I mean, I have to ask you to wrap up in about 30 seconds because we have a live case waiting.
All right. This was the trifurcation, including a disease, the distality of the left main. So the plan was to place the side branch stents first. This patient was going with angina for almost 6 months. Every time with BF because of mitral regurg. So we actually used a PA catheter to monitor the PA pressure, a long sheet, a balloon pump, and 7 French EBU catheter. So we placed the first stent. We did a rota because there was calcium at the left main, and we used Fielder XT first because it's quick one to go in, exchange over microcatheter.
Thank you, Professor. We're going to have to ask you to move to your summary slide, unfortunately, because we are really out of time.
Okay, so this is our final picture on this patient. We did a part and finally we had flows like this, 3 stents at the bifurcation track. And this patient was 6 months, very well, going up on his activity on a regular basis. Thank you indeed for this.
Thank you very much.